Recording in progress.
has to be established. And the government will have to establish that justifiability, not only on the basis of effectiveness, but on the basis that this is reasonably required. As Professor Figueroa indicated, millions of doses of vaccines have been administered, and there is no or very little evidence of any harmful effects. The fact of the matter is that some of the hesitancy to take the vaccine is based upon tradition and upon mistaken information. So that the background is that universally recognized, vaccine is universally recognized as a means of combating the spread of disease. And the effectiveness and safety can be verified by medical personnel. And a high percentage of vaccinated persons become immunized, and the safety which results to the person who is vaccinated as well as to their families and friends and the general population is a matter which is without doubt. The vaccines have been rigorously tested. They have obtained WHO approvals in many cases, and in some cases, the approvals are pending. But it has legitimate objectives. It has the objectives, as we have heard, of protecting society, stopping transmissions, protecting the individual himself or herself who is vaccinated, because the scientific evidence indicates that 90% of persons who are vaccinated do not get infected a second time and do not transfer the virus to others. So that in any constitutional test, those are factors which will be of critical importance. But the universal compulsory vaccination, which is really the subject matter of this discourse, is herd immunity. What is the percentage needed? That has not been scientifically established, but it's certainly in the level of 75 or 80%. The medical experts can indicate if they disagree with that. But that means that there are 20% of persons who may not be vaccinated and get herd immunity is achieved. Should that therefore mean that universality is not the necessary answer? If it is possible to obtain that percentage without compulsion, and that is something that we do not know yet. So because there is no justification in compelling the minority if the objective can be achieved. The proportionality test is an important test in free and democratic societies. And in order to justify the imposition of a mandatory regime, then it would have to be shown that that is the only reasonable way in which the objective can be achieved. It is clear, in my view, that certain segments of the society are to be treated differently. People who are vulnerable and likely propagators, like persons in the medical and hospital field, teaching profession, public and commercial operations, who come into contact with large numbers of persons. Those persons clearly fall into a category in which the justification is easier to establish. A man driving a tractor on acres of land who is alone on that land where he's conducting his farming operations is not in the same position as a taxi driver. So that initially at least, the imposition of the mandatory system on such a person is more difficult to justify. There are other measures that can be taken because one of the tests of justifiability is alternative methods. And as we have heard, there are indirect enforcement measures which can be taken that is not able to enter public places. restrictions on employment, whether in government or private. Termination of employment in some cases where the person is working in a very sensitive area and refuses to be vaccinated. The disciplinary procedures may require this. We have had, for instance, factories regulations which require that the factory workers should wear protective equipment, sometimes to protect not only themselves, but their co-workers, so that the recognition of the importance of being unselfish in relation to taking protective measures is a well-recognized principle. And we can have heightened restrictions. Some of the restrictions which are applied can be modified in relation to persons who are vaccinated, so that becomes an incentive. In other words, the case for mandatory vaccination has not yet been made out. So if it is going to be extended to all persons universally, and the principle of constitutional law which applies is that it must be demonstrably justified or reasonably justified. And that justification for the infringement of important rights can only be achieved by demonstrating that there are no alternatives which are reasonable for the achievement of the ultimate objective. So that I would be of the view that at present, where there is such a low level of persons who are vaccinated, the important thing is to push for the increase of the levels of vaccination, and then if the figure that is hoped for or is targeted is not achieved, then at that stage we can consider whether it should be made compulsory. But on the evidence which exists now, there is no basis, in my view, on which it can be made universally compulsory. But the compulsion would have to be targeted at specific groups. I'm grateful for the opportunity to contribute, and hope to hear from the questioners as to what are the issues which they would like us to address.
Thank you, Dr. Barnett. Thank you, speakers. There are quite a number of questions here. And the first question actually goes to something that Professor Antoine had indicated about soft laws and people having the option, for example, of choosing whether they travel to a certain place or not. And so Candace is asking, how can it be then that some vaccines are not being accepted for international travel and others are? So how do you work with a soft law of choice or giving choice in that context? Professor Antoine.
Well, I wasn't talking about it in that particular context that you, in terms of choosing the vaccine. I was simply saying that they may not tell you outright that you're forced, but indirectly you are forced. But it's a good point, and it's one of the points I suppose that will go against mandatory vaccine, especially in the third world, because we're not getting the supposed it's the best, by the way. I'm just saying that we take what we get, and we can be compromised. So no, so it didn't really mean it in that way when I said soft law though.
Can the panelists please turn your videos on at this point? And for Professor Figueroa, this is an interesting question. It says here, it is surprising that you have concluded that the vaccines should not be made mandatory at this point, after making a compelling case that they work to reduce death and severe illness. Is there any particular reason that you have taken this position?
The reason why I take that position is because we are still developing, we're still learning about the vaccines, and even more importantly, there is a significant degree of hesitancy and caution among sectors of the population about the vaccine, whether due to misinformation or just being cautious. So if you make it mandatory at this time, in a way, you are forcing individuals who do have reservations to take the vaccine. So I like how Dr. Lloyd put it, Dr. Lloyd Barnett, that at this point, let us vaccinate those who are ready for the vaccine, who are willing to take it, especially the most vulnerable. Encourage all adults to get it and see to what extent we can control the pandemic this way. However, if we find that we reach 80% coverage and we are still not controlling the pandemic, then we may have to consider putting in place laws that say, well, if you're going to travel, you need it. If you're a health provider, you need it. And at some point, we may have to say, everybody needs it in the public interest, but not at this time.
I think this is for the doctors again. Thank you, Professor. I think this is for the doctors again. It says, doesn't vaccines immunize people against an illness? As I understand it, you can still contract COVID-19 having been vaccinated. Isn't calling the injection a vaccine instead of a booster somewhat misleading?
That is squarely in Dr. Figueroa's camp.
Okay, so a vaccine, for instance, let's take measles. When you get the measles vaccine, especially if you get 2 doses, then you're almost invariably protected from getting the disease as well as becoming infected with the virus. But with some vaccines, including it appears with the COVID vaccine, it can protect you from the disease, but it may not protect you from getting the infection, getting the germ. With the COVID vaccines, it seems as if they're very effective in protecting you from getting severe COVID. Some persons who are vaccinated may get a mild form of COVID, and some persons may just get a COVID infection with the virus, the SARS virus, without any symptoms whatsoever. But it does reduce the likelihood of infection, and the dose, what we call the viral load that you actually get, appears to be less once you're vaccinated. I hope that's clear.
I think it is. But I have a follow-on to that question. So if the vaccines do not protect you against the disease, then is it accurate to speak of herd immunity?
No, the vaccines, the COVID vaccines do protect you against the disease, right? They do. The majority of persons are protected against the disease, but a minority, a few, may get a mild disease. And some people may get the germ without showing any signs of illness. So you can still get herd immunity because let's say 80% of people get vaccinated. And out of that 80%, 75% are protected fully from the disease, and only a small number still get the virus, but most of them don't pass it on to someone else. So you can still get herd immunity, but it is quite possible that we may, if we get even as much as 80% coverage with the vaccine, we may still get in other people who are not vaccinated, continuing to transmit the COVID and getting sick.
I suppose the confusion, Dr. Professor Figueroa, is this concept of the various vaccines having different levels of efficacy. It's a bit confusing for laypersons. So are you able to explain that in the context of what you just said and in the context of herd immunity or protection?
Yeah, this is an important point you're raising. And it's even a little more complicated than that, because when we use the term efficacy, we're talking about how the vaccine performs in the clinical trial. And the clinical trial may take place, different clinical trials for different vaccines take place in different continents at different times with different variants circulating, with different participants of different ages. So you have to be very careful of comparing the efficacy of the Pfizer vaccine and the Moderna with the AstraZeneca. Those of us who are in the field don't do comparisons like that. Only if you did both vaccines in the same population, in the same clinical trial at the same time, where you do a head-to-head comparison. So that's the efficacy from the clinical trials. All the vaccines are good, they're effective and safe. In the real life situation, when we roll out millions of doses of vaccine, we talk about effectiveness. How effective is the vaccine as against efficacy, which we reserve for the trials. And in the UK and the US, they've been doing lots of studies. And for instance, the studies in the UK show that the AstraZeneca, which we have been getting, and the Pfizer have comparable effectiveness.
And I like to say these days, sometimes I hear some answers that say good answer, like on Family Feud, for those fans online. That's a very good answer. Now, a series of questions have been coming in, and they've been asking about holistic medicine. So, you know, Caribbean people are very big on their holistic medicine. Dr. Figueroa, you know, in Jamaica, we like to talk about our herbs, such as turmeric, ginger, garlic, and so on. How do these figure into either prevention or treatment of the virus as an alternative to mandating?
Well, the healthier you are in terms of your diet, physical activity, the healthier you are, it means that your immune system is stronger. But no matter how strong your immune system is, with certain infections like measles or COVID or certain other infections, if you are exposed, you are likely to get infected. So turmeric or other herbs of themselves are not going to protect you, nor is sunshine, by boosting up the vitamin D of itself, going to protect you. So that is good, we support it, but you need something more. You need the vaccine, and you need two doses.
Thank you so much. So someone else is asking, is it right to dismiss objective medical and scientific perspectives from medical professionals who have genuine concerns and queries about the new COVID-19 vaccines as simply misinformation? Is it right that many of these medical professionals are censored across many platforms?
Well, no, I think we need to be respectful of people who have reservations, who have concerns, who have questions. I think it's only natural. And health providers are also humans. They have their own fears, anxieties, and concerns. So I don't think that there is widespread censoring or condemnation of people who have concerns or reservations. And I think we need to be patient, and, you know, it's going to take time, and people need time to process. The main thing is to encourage people to turn to credible sources, including their practitioners, and they have to, over time, you just have to be patient. I don't think there's any simple solution here. And that's another reason to me why I think it's too early to be talking about mandatory vaccination for COVID. But let's say the variants really begin to cause a lot of trouble and health workers are falling down because they can't, they are getting sick as well. Then the question arises, I don't know whether it was Professor Antoine or Dr. Barnett who said it, there are policies in hospitals in the US and elsewhere where health providers have to be vaccinated with some of the established vaccines. All our medical students have to be vaccinated fully, included from hepatitis B and this sort of thing, not yet influenza. But even now we're thinking, should we not require health providers to be vaccinated? So we have to always put these things in context. I think all panelists agreed that whatever we do must be balanced. Proportionality, I've made notes in terms of the legal principles, and they sound very, very reasonableness, proportionality, balance, protection of the minority view. But at some point, you then have to draw the line. Yes, we need to use seat belts. We need to chlorinate our water.
Okay, so speaking of proportionality and balance, I suppose this question is going to be for Dr. Barnett and Professor Antoine. Is there any value, if we have to consider mandatory vaccinations, is there any value in looking at the societies according to sector, and meaning in terms of how they interact with people? So for example, I heard Dr. Figueroa just talk about doctors or tourism workers or taxi drivers, transportation, and so on. Is there any value in that kind of approach?
Yes, I gave some examples and others gave, but clearly the person who is exposed to many persons in the short term, like a taxi driver or the person at the entrance of a hotel, or the person who is the ambulance driver who is going to be taking ill persons around and taking them into the hospital. Persons who are so exposed to others, I think, fall in a special category.
Yes, I also said more or less the same in terms of looking at the risk factor, whether it's in the private sector, whether we're talking about a law and constitutionality. There is a stronger case to be made for high risk occupations. Healthcare workers would obviously be one, but it's not just the healthcare workers. And the question of cost might also come in. I'm speaking to someone recently, an employer saying, well, we have to spend so much quarantining every week, so at what point is it justifiable to say, look, I simply, it's such a high risk environment, I require to take a vaccine. So yes, I think the sector is very important, or the type of work that you do, I should say.
And there have been cases dealing with children and hospital workers. And there's a European Human Rights Court decision relating to children. And that, although children might be more resistant to the virus, children operate within schools in the company of many other persons coming from different homes, so that the special requirement in relation to children is probably more easily justified.
Yes, thank you, Dr. Barnett. Thank you, Professor Antoine. Dr. Mitchell?
Yes, I just wanted to put a public health spin on this, if you don't mind. The smallest of our societies basically almost, and I don't want to use a strong term as dictates, but in the Grenada context, for example, with 110,000 persons, it is like if you don't vaccinate persons who work on the front line, say for example in the hotel industry, and they have families that sort of like go to school, go to work, and mixed in one sort of like in 24 hours, you can have that person mixing with everyone. And so the possibility of infecting your families, persons who ride on the bus, persons who do any other thing is so high that it is the risk involved in terms of taking a public health look at it is so great that it adds to the value of if you're on the front line in a hotel, for example, as a worker who takes care of the linen and so forth at a hotel where you have guests coming in, that person is on the front line, but that person lives in a house with 3, 4, 5 other people. And so do you mandate that that person also take the vaccine because of the risk they pose to their families out there in a small society like Grenada and other similar societies in the region? So I like the conversation about risk, but because of the context we live in, the risk is almost universal in terms of where we live and how we exist in the region.
Thank you, Dr. Mitchell. Someone is asking, and this is for either medical doctor, would you consider the present stage of vaccines to be a clinical trial?
That again is Professor Figueroa, and he's the expert on that.
Yeah, we would not consider, it's extremely important to monitor the safety and effectiveness of the vaccine as it is rolled out. However, that is not considered to be a clinical trial. A clinical trial has certain parameters to it. For instance, the way that the clinical trials are done to prove or establish the evidence for whether a drug is effective or a vaccine is effective, it needs to be, the participants need to be randomized either to the intervention, to the vaccine, or to the placebo or alternate treatment. And the observers who are doing the study and the participants who are subjects within the study, neither of them, neither the observers nor the participants, must know who is receiving the vaccine and who is receiving the placebo. And when the results are documented and put in a database, the persons who analyze the data, they only know group A, group B. They don't know which group is the treatment group or the vaccinated group and the placebo group. And this is of critical importance because what you're doing is you're trying to remove the subjective element, the subjective human element from an assessment of the results. So you can imagine that when you do a clinical trial, it is a randomized, double-blind, controlled situation. And even with the adverse effects, you seek out, you ask the participant, if not daily, every week, do you have any adverse effects? Do you have headache? Do you have, fatigue, fever? So it is a very controlled situation. Obviously, when you roll out millions of doses, you can't control it as closely as that, but you still monitor, and any severe adverse event is to be reported and investigated. Over.
I'm going to shift a little bit. Most of the questions are asking about the medical side, and I'm going to go back to those questions. I'm asking persons who are posting your questions in the chat to put them in the Q&A. So okay, let me go back to the medical questions. Is there any truth to Europe refusing to accept persons with the type of AstraZeneca that was made in India? This person has asked 3 questions. I'm going to put all 3 on the table. So is there any truth to Europe refusing to accept persons with the type of AstraZeneca that was made in India? Also, will the AstraZeneca work against the new variants that are out now? And will there be a 3rd and 4th dose to come, especially in light of the fact that one cannot mix vaccines? And can any light be shed on the Cuban vaccine candidates in terms of updates on effectiveness? Before you answer, doctors, I happen to know that in Ontario, at least, they are mixing vaccines. They are mixing Pfizer and Moderna. They are mixing AstraZeneca and Moderna, AstraZeneca and Pfizer. So over to you, doctors, on these
Maybe
questions.
I'll begin the answer. The European Medicine Agency is the regulatory authority that rules on which medications and vaccines may be used in Europe. They have put out a release saying, well, someone has put it out, saying that they will not accept the Covishield, which is the AstraZeneca that is produced at the Serum Institute in India. The Serum Institute is a producer that produces the majority of childhood vaccines that we use globally. So they have an impeccable reputation, and they had an agreement with the AstraZeneca Oxford University that developed the AstraZeneca vaccine, and they licensed Serum Institute to produce the same vaccine in India at Serum Institute. WHO accepts that vaccine, and all the experts agree that it is equivalent to the AstraZeneca produced in Sweden. So I'm not sure if it is a technical issue that the regulatory authority, the European Medicine Agency, is saying Serum Institute must submit their data to them, Covishield, and when they submit that data, they will look at it and allow that vaccine. But the WHO has made it clear that even if that is a technicality, it is a discriminatory judgment. You cannot, because some of the people, even in the UK, got the Serum Institute AstraZeneca and not the Swedish AstraZeneca. So that's the first. All the current vaccines, including AstraZeneca, are effective against all the variants of concern. There may be a little decrease in effectiveness of these vaccines, but they're all highly effective against the variants and will protect against severe disease and death. The mixing and the mixing and matching that the moderator just spoke about, they're doing studies now where they're showing that if you get AstraZeneca first, then Pfizer, or Pfizer first, then AstraZeneca, you get a good immune response. But they have not done it in a large enough trial with enough subjects to show that it established that it actually in real life will prevent you from becoming infected. Though most experts accept that because the antibodies are there, you most likely are protected. So they want to do some more studies. Canada has taken the decision, because they're having difficulty getting sufficient AstraZeneca, that those persons who got the first dose AstraZeneca, they will get a second dose of Pfizer or Moderna. So they're going ahead with that. WHO is open to that in situations where a country simply cannot get the same vaccine to give the first dose and the second dose, because there is a significant scarcity of vaccine for many countries, partly because there's not enough production capacity, but also because many of the advanced countries have monopolized the vaccine market through bilateral contracts. They have purchased or contracted excessive amounts. They have reserve amounts. And there's a campaign by the WHO and the experts to try and convince these countries, make available more of the vaccine to those countries that are not getting the vaccine. So I don't know if I've covered all your points, moderator.
I think you have. Thank you very much. Professor Antoine, you made reference to the United Methodist case, I think it is called, in that class action lawsuit in Houston, Texas. And you made reference to the passage where the judge indicated that when they dismissed the case and said that it is not coercion, the Methodist is trying to do their business of saving lives without giving them the COVID-19 virus. It's a choice made to keep staff, patients, and their families safer. Bridges can freely choose to accept or refuse a COVID-19 vaccine. However, if she refuses, she will simply need to work somewhere else. And this is to both yourself and Dr. Barnett. In the context of our Constitution, in the context of our labor laws, would you expect a similar kind of ruling coming out of our courts?
A very good question. On the parts of it that speak to experimental and so on, and I know lots of people have that question in chat. I myself am a human being like everybody. I just had an accident. I was a bit nervous about taking a vaccine. All of that I understand. But if we compare with the HIV, they said, okay, you go with the traditional science, right? So that's the first thing. So they were quite dismissive in relation to that whole thing about the Holocaust and experimental, all that was discussed in that Bridges case. Okay, we know in HIV, people thought you could get HIV from touching people and so on, and they said, no, we must go to the science. So that's where I think the law would be grounded in the sort of the traditional orthodox science, the WHO approvals, etc. All right, but where I depart from that Bridges case is when they say, well, you could just fire the person, right? So although I think there might be situations where that might be the only option, I would suggest it is not an easy fit for the Commonwealth Caribbean, where we have fairly strong laws on unfair dismissal and so on. Perhaps not everybody is as strong, but generally that's where we are. And I would suggest that a more proportionate response in terms of the penalties and perhaps where a state might need to intervene is to say, okay, you may be able to require your workers to take a vaccine in a high risk environment, as we've all said, but if they refuse to, whether it's because they're religious reasons or whatever reason at all, you should make alternative arrangements. So, for example, you can ask the person to be tested every week and say, all right, you want to, but we don't come to work unless I know there's a test. You can work at home, you can have all those other things. I don't think it would be easy to be able to dismiss a person who refuses a vaccination. So I depart from that at that point.
Dr. Barnett, any thoughts?
Yes, I agree because this case doesn't go as far as to justify mandatory universal vaccinations. It was concerned with hospital workers.
Yes.
It was really one of the first categories that you could quickly justify the imposition of compulsory vaccination. And the judge did say that there could be exceptions in relation to people who had religious beliefs that preclude vaccination, for instance. So it's not a case in favor of mandatory universal vaccination.
Thank you, Dr. Barnett. Thank you, Professor Antoine. So Shireen is asking this question for you, Dr. Barnett. Notwithstanding one's right not to be vaccinated, how does that right balance against the right of others not to be infected? And her context is frontline workers, patients, and in particular teachers and students in the school system.
Well, those are the very examples we gave of persons who have to interact with large numbers of persons. And those persons have to be treated as coming within the first category were exposed to the mandatory vaccination regime and likely to be justified on the basis that they are not only exposed themselves, but they are exposing other persons. And anyone who works in that type of environment, like a barkeeper, for instance, a bartender who's serving lots of people, a waiter in a restaurant, those persons have to be treated as in a special category.
Quite a number of questions. Thank you, Dr. Barnett. Quite a number of the questions are directed at also treatment. So we know certainly in Jamaica, there's a lot of tension relating to, is it ivermectin? And this resistance to utilizing that method of treatment. So I suppose this is for Dr. Figueroa and Dr. Mitchell, if you have that issue as well in the OECS.
Unfortunately, we have taken the method of ensuring that we have very strict protocols, and so far we've been particularly fortunate, and we have not had many cases hospitalized in Grenada, and so we have not had the tension of having to discuss heavily issues surrounding treatment. And so the ivermectin debate has not hit our shows very prominently. So I would sort of like deflect again to Professor who knows a lot more than me where that is concerned.
Yeah, with respect to the ivermectin, the WHO actually tracks all the studies, especially the clinical trials in which ivermectin is being used. So they have in what they call a living data set. As new results become available, they put it on the data set. The last time I looked at the data set, you can actually manipulate it, and you can take all the clinical trials and you can do an analysis which allows you to put the results of the different trials together. And when you do that, there are several clinical trials that have been done of varying quality, and the overall result is that there is no significant, it does not show that ivermectin has any significant effect to prevent death, to reduce the time in hospital, or to ease the severity of the symptoms. So the clinical trials have not, which are the gold standard, have not provided the evidence to suggest that ivermectin is effective. There are scores of observational studies that strongly suggest ivermectin should work. But most of you may recall that we went through this same situation with hydroxychloroquine, where the observational studies were very compelling, and there were many distinguished scientists who came out and said, we've got to use hydroxychloroquine. And when they did large clinical studies, including a multicultural trial that the WHO ran, and it clearly established that hydroxychloroquine was not effective and in fact could cause more harm than good. So there is a very strong adamant lobby calling for ivermectin use, but most of us within the field of epidemiology and immunization, most of the experts believe that we need to have more trials before you can just wholesale turn to the use of ivermectin.
Chair, I just wanted to alert you that I've been reading the chats and many people are saying they can't get into the Q&A and they can't cut and paste. So you may want to see if you could pick up some questions. They're a
In
bit
the chat.
frustrated.
Okay, so in the chat, as also in the Q&A, I see that some persons are asking about the long-term effects of the COVID-19 vaccines that are currently in use,
Well,
as well as they want to know whether the vaccine hesitancy could be classified as irresponsible behavior.
no, I don't think that most vaccine hesitancy is irresponsible. You know, people vary. Some people are more cautious than others. But I don't think we can just say that it is irresponsible. Persons who knowingly circulate misinformation, then that is irresponsible. But I don't think most people who have reservations, concerns, questions are being irresponsible at all. There was another aspect to your question, moderator.
What are the long-term effects of the COVID-19 vaccines that are currently in use?
Right. So the most adverse effects for all the vaccines that we know they usually occur early or soon after, within days of getting the vaccine. There are very rare instances where one or two vaccines have rare adverse effects that emerge later on. So far, all these severe adverse reactions that we are aware of have occurred relatively early. The ones that I am aware of, one, when they rolled out the Pfizer and the Moderna, there were a few people who immediately got a very severe allergic reaction requiring to get an injection of antihistamine, adrenaline. Luckily, none of them died, because when we're giving vaccines, we observe people for at least 15 minutes and you have adrenaline and other recovery things right there in place. So that's one side effect. Anyone who has a history of having an allergy to any constituent part of the vaccine is told, don't take the vaccine. Then the AstraZeneca blood clots I've told you about. They have found, as they rolled out the Pfizer, in the younger age group, that there are younger men appear to get a mild form of myocarditis. This is an inflammation of the heart. I'm not aware of any deaths or any serious disease. It seems to be self-limiting, but it is occurring at a rate which is more frequent than what would be expected in the general population. They saw this in Israel, they're seeing this in the US. Those are the three main serious side effects that I am aware of. When you look at the principles to do with immunization, most of the experts, we can't play God and say there may not be some ill effect, 2 years from now. But that is not seen in our field with the vaccines that we're familiar with. And the techniques that are being used now are more sophisticated. They are purer. The standards, the rigor, it's much more rigorous than the earlier vaccines that were produced. Some of the earlier vaccines that were produced would not be passed by the current regulatory authorities. So the risk, and in life, nothing is 100%. So you have to weigh, what is the risk? What is the benefit? The benefit of preventing COVID is outweighs by far the current risk that we are aware of. And even if you factor in an additional risk that we don't know about, but is real, then the benefit still outweighs the risk. Over.
Thank you so much. There were about 200, well, over 200 questions. I cannot take all of the questions because time is upon us, but I must ask this last question. Is there a disparity in side effects of the vaccines between male and female?
You know, with COVID, it seems as if women may get COVID more readily than men, but men die from severe COVID more readily than women. But this is not a major difference, but we do notice that difference. When it comes to the vaccines, the blood clots, the very rare blood clots with AstraZeneca and Johnson & Johnson do appear more frequently in younger women than older persons or younger men. And the myocarditis appears more in young men than anybody else. So that is the subtle differences at this point. And in fact, the blood clots seem to occur more readily in, the Germans have reported it, a couple Nordic countries have reported it. The UK has not reported as many blood clots as has been reported in Europe. And then in the developing countries, where reporting is not as rigorous, unfortunately, but I am not aware of any reports. I may be missing them, but I'm not aware. No, there may well be cases, but I am not aware of reports of the blood clots in developing countries so far. So there are differences between continents and countries.
So Professor Figueroa, Dr. Mitchell, Professor Antoine, Dr. Barnett, I want to thank you very much for this engaging, spirited, and informative presentation. But I will be taking over from our first Vice President of ACBA, Donovan Walker, if I were to continue, and he is here to present and move the vote of thanks. Thank you so much.
Thank you, Madam Moderator, Georgia Gibson Henling QC, and my friend, you did an excellent job at your moderating and leading these proceedings. Good afternoon, my friends throughout the region. At one time, there were 774 attendees at this conference. So I want to thank all of those who came and listened and asked your over 200 questions. I'm sorry we could not get to it, but I suspect that we would be having our panelists stay way past their bedtimes. I'm pleased to say that every country in CARIFORUM was represented today at this particular seminar. We had colleagues from as far away as the Netherlands who were here, Europe, England, the United States, Canada, most importantly, the Caribbean. It would be remiss of me not to just quickly acknowledge a few of our colleagues who attended. Dr. Peter Maynard, who is the Vice President of the Commonwealth Lawyers Association. And I would just indicate on his behalf that the CLA is actually having its conference in the Bahamas this September. And of course, those of you who have never been to those conferences, please try and support the CLA. It's going to be an engaging in-person conference. Sir Dennis Byron, former president of the CCJ, other judges of the CCJ, including Justice Peter Jamadar, who is the president of the Caribbean Association of Judicial Officers. I note that the Chief Justice of the Eastern Caribbean Supreme Court, Justice Janice Pereira, the judges of appeal from the Eastern Caribbean Supreme Court, the judges of the CCJ have all been here. The Andre Lewis, who is the head of the Caribbean Congress of Labor, is also with us today. And so on their behalf and on behalf of the 774 attendees, I really want to thank the Honorable Dr. Lloyd Barnett, OJ, Professor Rosemary Bell-Antoine, Dr. Peter Figueroa, Dr. George Mitchell, and Georgia Gibson Henley, Queen's Counsel, for this wonderful, wonderful presentation. You see, friends, colleagues, COVID-19 is a test of societies, of our governments, of communities, and of individuals. And it's clearly now the time for solidarity and cooperation to tackle the virus and to mitigate the effects, often unintended, of measures designed to halt the spread of the virus. This particular program has certainly highlighted the capabilities locally, the skill sets regionally, to tackle not only the medical aspects of these things, as Dr. Mitchell and Dr. Figueroa have evinced, but in terms of looking at the legal aspects and the rule of law and the constitutionality of how we're going to deal with this, as Professor Antoine and Dr. Barnett have evinced. As OCBA, the Organization of Commonwealth Caribbean Bar Associations, we are committed to legal pedagogy, to learning and development in the region. And in fact, I would like you all to take note, on Saturday the 17th, the Law Summit of the OCBA will be taking place. This is where all the presidents of all the Caribbean Bar Associations meet, and that will take place between 10 a.m. to 1:30 Eastern Caribbean time. Emails will be circulated in that regard. Our special guest speaker, who will speak between 10 and 11, is none other than Sir Dennis Byron and others in relation to the continuing legal education seminar that OCBA will host during our annual Law Summit. On behalf of your presenters and your moderator, and on behalf of OCBA, let me thank the Law Association of Trinidad and Tobago, led by their new president, as well as the internal team at LATT, led by Jenna Marie Acqui, who really did a great job in allowing us to use their technology and their platform to host this. Please, friends, stay safe, stay healthy. I wish nothing but the best for you and your families. And I think taking Dr. Figueroa's advice, get vaccinated. It makes good sense. And we're all sensible people. So on behalf of OCBA, it's just left for me to say, thank you very much all. On behalf of our president, Ruggles Ferguson, thank you very much, everybody. Stay safe. Have a good evening. One love.
Thank you.
Thank you, everybody.
Thank you, everybody.
Thank you.
Thank you,
Thank you.
moderator. Great job.